83. On your routine MR reporting session, a lumbar spine shows normal alignment and multilevel low signal on both T1 and T2 in the intervertebral disc centrally, with disc space narrowing. What is the most likely diagnosis? A. CPPD-B, achronosis C, amyloidosis D, renal osteodystrophy E, gout. Musculoskeletal system arthritis colitic type, ankylosing spondylitis, isolated joint involvement. Fatty liver, gallstones associated with ileal-Crohn's disease. Ileal-Crohn's disease. Ocular system uveitis/iritis, episcleritis, scleromalacia, corneal ulcers, retinal vascular disease. Metabolic system growth retardation in children and adolescents, delayed sexual maturation. Renal system calcium oxalate stones. Levine J.S., Borkhoff R., extra-intestinal manifestations of inflammatory bowel disease. Disease. Gastroenteral hepatal, NY. 2011, 7, 423541. 83, B. Achronosis causes of intervertebral disc calcification include the following. Degenerative disc disease is a relative common cause for disc calcification. Alkaptonuria, or achronosis, results in dense central calcification affecting the nucleus pulposus and is associated with generalized osteopenia. Changes often start at the lumbar spine. Ankylosing spondylitis is a recognized cause, associated findings helping in narrowing the diagnosis. Calcium pyrophosphate dehydrate deposition disease, CPPD, hemochromatosis and hypervitaminosis D can result in calcification of the annulus fibrosus. Transient intervertebral disc calcification is seen in children, typically in the cervical spine, and spontaneously regresses. Other recognized causes of disc calcification include juvenile chronic arthritis, amyloidosis, poliomyelitis, acromegaly, hyperparathyroidism, trauma, and postoperative discs. 84. A 64-year-old man with nasal obstruction and bloody nasal discharge showed a large heterogeneous mass in the nasopharynx on CT sinuses. There was loss of normal parapharyngeal fat planes with non-enhancement of the ipsilateral jugular vein. What is the diagnosis? A. Inverted papilloma. B. Nasopharyngeal carcinoma. C. Juvenile angiofibroma. D. Lymphoma. E. Midline granuloma. 85. Bergener Fa, ETAL Differential Diagnosis in Conventional Radiology. New York, Theme, 2008. Eisenberg R.L. Clinical Imaging, an Atlas of Differential Diagnosis. Philadelphia, Pa, Lippincott Williams and Wilkins, 2003. Chapter 10. Test Paper 5, Answers. 292. 84b. Nasopharyngeal carcinoma imaging is crucial in delineating the extent of local tumor extension, as well as detecting nodal metastases, which are present in the vast majority of patients at the time of diagnosis, 75% 90%. Nasopharyngeal carcinoma, NPC, usually presents with intermediate signal intensity, higher than the muscle signal, on T2, weighted images, low signal intensity on T1, weighted images, and enhanced to a lesser degree than does normal mucosa. 82% of NPCs arise in the posterolateral recess of the pharyngeal wall, Rosenmuller fossa. Larger/more aggressive tumors may extend into any direction, eroding the base of skull and passing via the eustachian tube, foramen lacrum, foramen ovale, or directly through bone into the clivus, cavernous sinus, and temporal bone. Invasion of the parapharyngeal space is associated with an increased risk of distant metastases and tumor recurrence. Following administration of contrast, the tumor mass and nodal metastases usually demonstrate heterogeneous enhancement. Careful assessment of cervical lymph nodes is essential due to the high rate of nodal involvement at the time of diagnosis. Cranial nerve involvement and venous occlusion is best demonstrated on post-contrast MRI. MRI. Razek Aka, King A. 85, a 77-year-old man with progressive worsening of breathing and chest pain presented to his family doctor, who sent him for a chest X-ray to exclude infection. The chest X-ray showed multiple ring shadows, and he was sent for an HRCT. The HRCT confirmed the presence of multiple small cystic spaces in both lungs. All of the following disorders of the lung can be associated with this HRCT pattern, except A. Tuberous sclerosis, B. Langerhans cell histiocytosis, C. Lymphocytic interstitial pneumonia, D. End-stage interstitial fibrosis, E. Cole workers pneumoconiosis. 86. King A. MRI and CT of nasopharyngeal carcinoma. AJR AMJ Rentgenol. 2012, 198, 11118. 85. E. Cole workers pneumoconiosis. Many diffuse lung diseases may manifest cysts as the primary abnormality, although lymphangioliomyomatosis and Langerhans cell histiocytosis, LCH, are the most common to present with diffuse lung cysts. Others include lymphocytic interstitial pneumonia, follicular bronchiolitis, amyloidosis, light chain deposition disease, Birt-Hog-Dube syndrome, end-stage fibrosis, honeycombing, and cystic metastasis, leiomyosarcoma, synovial cell sarcoma, epithelioid cell sarcoma, and endometrial stromal sarcoma. 86. A 67-year-old man with worsening abdominal pain and LFTs shows a peripheral mass in the right lobe of the liver. Contrast-enhanced dynamic MRI done for further characterization. Confirm the lesion seen on US with evidence of liver capsular retraction consistent with Chapter 9. Test paper 5, questions. 258. Desmoplastic reaction commonly associated with peripheral cholangiocarcinoma. All of the following are risk factors except A. Radium exposure, B. Chronic hepatitis C. Primary sclerosing cholangitis, D. Thoracic exposure, E. Clonocai sinensis infection. Semen DM, ETAL diffuse cystic lung disease at high resolution CT, AJR AMJ Rentgenol. 2011, 196:130511. 86. B. Chronic hepatitis. There are a number of recognized risk factors for cholangiocarcinoma that all share the common feature of chronic biliary inflammation. Among these risk factors, infection with liver flukes, e.g., Episthocus vivarini, and Clonocai sinensis, and hepatolithiasis are common causes of cholangiocarcinoma in endemic areas. Dietary or endogenous nitrosamine compounds associated with parasitic infections also play an important role as cofactors in carcinogenesis, probably due to the carcinogenic effect of nitrosamine compounds on the proliferation of epithelial cells of the bile duct. Cholangiocarcinoma arising from a cirrhotic liver may be surrounded by a fibrotic pseudocapsule, which is an unusual finding in cholangiocarcinoma arising from a non-cirrhotic liver. In such cases, capsular retraction is noted along the tumor surface. This capsular retraction may be seen in some hepatocellular carcinomas, HCCs, with cirrhotic stroma but is more suggestive of cholangiocarcinoma. Cholangiocarcinoma can develop in a congenital choldocal cyst with a lifetime risk of 10% 15%. In addition, a European study showed that a history of alcohol-related liver disease, cirrhosis, various bile duct diseases, chronic inflammatory bowel disease, or diabetes may increase the risk of development of cholangiocarcinoma. Chungya, ETAL varying appearances of cholangiocarcinoma, radiologic pathologic correlation. Radiographics. 2009, 29 683 700. 87. B. Struma ovarii. Struma ovarii is a infection. 87. A 59-year-old woman with an apparent lump in the lower abdomen, weight loss, and new onset tremor was sent for an MRI of the pelvis to investigate. Sagittal T2W MRI showed a multiloculated, heterogeneous left ovarian lesion with very low signal intensity. Corresponding axial in-phase and out-of-phase images revealed a hypointense mass with chemical shift artifact in its ventral aspect. Axial post-contrast T1W MRI showed significant enhancement of the ovarian lesion. What is the diagnosis? A. Brenner tumor. B. Struma ovarii. C. Ovarian thecofibroma. D. Mucinous cystadenoma. E. Endometrioma. Rare ovarian lesion that accounts for 2% of ovarian teratomas. Struma ovarii is a highly specialized form of ovarian teratoma and is composed entirely or predominantly of thyroid tissue. About 5% of patients develop clinical evidence of hyperthyroidism. At US, struma ovarii has a non-specific solid, cystic appearance. MRI demonstrates a loculated cystic mass with variable signal characteristics. Cystic spaces may show marked T2 hypointensity and intermediate T1 signal intensity due to the thick, gelatinous colloid of the struma. Some locules. Chapter 10. Test paper 5, answers. 293. May contain microscopic fat, as indicated by signal drop-off and chemical shift artifact on a post-phase T1 weighted MRI. Struma ovarii typically demonstrates strong enhancement of the solid components on post-contrast T1 weighted MRI. Struma ovarii are benign in 95% of cases and usually occur in premenopausal women. Therefore, preoperative diagnosis is essential to avoid unnecessary radical surgery. Cause Hopper A, ETALT2, hypointense adnexal lesions, an imaging algorithm. Radiographics. 2012, 32, for 1047-64. 88. 88. Posteromedial corner, PMC, of the knee involves the following structures. A. Semimembranosus tendon and posterior oblique ligament. B. Popliteus muscle and arcuate ligament. C. Iliotibial band and biceps femoris. D. Gastrocnemius. 88. A. Semimembranosus tendon and posterior oblique ligament. The PMC contains the structures lying between the posterior margin of the longitudinal fibers of the superficial medial collateral ligament and the medial border of the posterior cruciate ligament. The PMC has 5 major components: the semimembranosus tendon and its expansions, the oblique popliteal ligament (OPL), the posterior oblique ligament (POL), the posteromedial joint capsule, or simply the posteromedial capsule, and the posterior horn of the medial meniscus. Lundquist RB, ETAL posteromedial corner of the knee, the neglected corner. Radiographics. 2015, 35, 411 23 37. 89, D, carotid body tumor. A carotid body paraganglioma arises within the carotid body and gastrocnemius and PCLE, medial reticulum and medial collateral ligament. 89, a 53-year-old man with lump in the right side of the neck was investigated with US showed a solid lesion closely related to the carotid artery. Axial CT showed a large, well-defined mass bulging into the nasopharynx. Multiplanar reconstructed images revealed characteristic splaying of the carotid bifurcation. What is the diagnosis? A. Glomus jugular. A. B. Glomus tympanicum. C. Thymic cyst. D. Carotid body tumor. E. Glomus vagal. 90. While reporting a plain radiograph of the knee in a 5-year-old child, you notice premature closure of the distal femoral growth plate. Which of the following features in the clinical history would not explain this? A. Localized radiotherapy to the leg. B. Hypervitaminosis. A. C. Osteomyelitis. D. Previous trauma to the knee. E. Hyperparathyroidism. Characteristically splays the bifurcation of the CCA. As the tumor enlarges, it encases but does not narrow the caliber of the ECA and ICA. With disease progression, the lesion may involve the lower cranial nerves and adjacent pharynx. Superior extension to the skull base and invasion into the intracranial cavity has also been reported. The typical CT appearance of a carotid body tumor is a well-defined soft tissue mass within the carotid space of the infrahyoid neck. The underlying hypervascularity of the tumor results in homogeneous and intense enhancement following intravenous administration of contrast material. Splaying of the common carotid bifurcation is very suggestive of a carotid body tumor. The characteristic CT appearance is that of a uniloculated or multiloculated, hypoattenuated cystic mass adjacent to the carotid space. The mass may extend into the mediastinum. The signal intensity of thymic cysts on Mr. images is low on T1 weighted and high on T2 weighted. Images. The glomus tympanicum tumor manifests as a small discrete mass arising from the cochlear promontory and confined to the tympanic cavity. Ossicular destruction is not typical, although encasement is frequent in larger lesions. The vagal paraganglioma appears similar to the carotid body tumor with some exceptions. These masses displace both the ECA and ICA anteromedially, separating these vessels from the IJV. In addition, extension into the suprahyoid carotid space is seen in approximately 2/3 of vagal paragangliomas, whereas it is uncommon with carotid body tumors, up to 8%. Kolar KK, ETAL congenital cystic masses of the neck, radiologic pathologic correlation. Correlation. Radiographics. 1999, 19, 112146. Raub, ETAL paragangliomas of the head and neck, radiologic pathologic correlation. Radiographics. 1999, 19:16, 0532. 90, E. Hyperparathyroidism physiofracture is the most common cause of bone bridging across the growth plate, but growth arrest may also be due to other insults, infection, therapeutic radiation, metabolic or hematologic abnormality, tumor, burn, frostbite, electrical injury, sensory neuropathy, microvascular ischemia, or insertion of metal. Premature fusion of the growth plate has also been reported in patients with hypervitaminosis A. Craig J.G., ETAL premature partial closure and other deformities of the growth plate, MR imaging and three-dimensional. 91, a 45-year-old trumpet player presented with a lump in the right side of the neck, which appeared to grow in size when the man was playing the trumpet and become less prominent when he was relaxed. CT showed clearly defined, round, radiolucency in the soft tissue of the right side of the neck lateral to the larynx. A normal barium swallow report was available in the system for suspected swallowing difficulty performed at a different hospital. What is the likely diagnosis? A. Internal laryngocele. B. External laryngocele. Chapter 9. Test paper 5, questions. 259. C. External laryngocele with infection. D. Laryngomalacia. E. Tracheomalacia. 92. A 67-year-old man with a progressive restrictive pattern of pulmonary function test and increasing chest tightness was sent for an HRCT for character. Craig J.G., ETAL premature partial closure and other deformities of the growth plate, MR imaging and three-dimensional modeling. Radiology. 1999, 210, 383543. Chapter 10. Test paper 5, answers. 294. 91. B. External laryngocele. Simply stated, a laryngocele is a dilated laryngeal saccule, and there are three types, internal, external, and mixed. Approximately 40% of laryngocele are internal. These laryngocele are confined to the larynx and do not pierce the thyrohyoid membrane. External laryngocele, 26% of cases, extend through the thyrohyoid membrane at the point of insertion of the superior laryngeal nerve and vessels, neurovascular bundle. The component superficial to the thyrohyoid membrane is dilated, and the saccular portion inside the membrane is normal in size. Finally, mixed laryngocele, 44% of cases, have abnormal dilatation of the saccule on both sides of the thyrohyoid membrane. The association of laryngocele with laryngeal carcinoma is well documented. Investigators worldwide have reported an increased frequency of laryngoceles in patients with laryngeal carcinoma. On CT scans, a laryngocele appears as a well-defined, smooth mass in the lateral aspect of the superior parlaryngeal space. Internal laryngoceles will be limited by the thyrohyoid membrane. External and mixed laryngoceles lie superficial to the thyrohyoid membrane at the point of insertion of the superior laryngeal nerve and vessels, neurovascular bundle. The attenuation of these lesions may vary, depending on the amount of secretions, air and soft tissue from an associated laryngeal neoplasm. Polar KK, ETAL congenital cystic masses of the neck, radiologic pathologic correlation. Radiographics. 1999, 19, 112146. 92. B. Lymphangitis. The most common malignancy associated with lymphangitis carcinomatosa is bronchogenic carcinoma, most commonly adenocarcinoma, followed by breast, GI malignancies. Characterization. HRCT showed nodular septal thickening with further bronchovascular nodules and thickening. Which one of the following disorders is most likely to be the cause? A. Pneumoconiosis. B. Lymphangitis. C. Lymphocytic interstitial pneumonia. D. Hypersensitivity pneumonitis. E. Churg-Strauss syndrome. Malignancies, stomach and colon, and prostate cancer. Chest CT is more specific and sensitive than CXR for the diagnosis of lymphatic metastasis. On HRCT, there is variable, smooth, irregular or nodular thickening of the interlobular septae and bronchovascular bundles, which often have a beaded appearance. Another characteristic feature is either smooth or nodular thickening of the peribronchovascular interstitium. Similar changes can be seen along the fissures. In many patients, the abnormality is unilateral or patchy. Pleural effusion and hilar adenopathy are associated. Prakash P. ETAL FDG PET/CT in assessment of pulmonary lymphangitic carcinomatoses. AJR AMJ Rentgenol. 2000. Syndrome. 93. A 48-year-old man with a history of alcohol excess is admitted with a variceal bleed. Regarding upper gastrointestinal varices, which of the following statements is correct? A. They are the result of hepatopetal blood flow from the left gastric vein and splenic vein to the superior mesenteric vein. B. Esophageal varices tend to bleed more severely than gastric varices. C. Splenic portography is the first-line investigation for assessment. D. Barium studies can detect gastric varices in approximately 75% of cases evidenced by lobulated folds and polypoidal fundal masses. E. Gastric varices bleed more frequently than esophageal varices. 2010, 190 for colon 231-6. 93. D. Barium studies can detect gastric varices in approximately 75% of cases evidenced by lobulated folds and polypoidal fundal masses. Gastrointestinal varices occur as a result of hepatofugal flow from the left gastric vein and splenic vein to the superior mesenteric vein. This usually occurs secondary to liver cirrhosis, but isolated splenic vein occlusion with pancreatic disease can also be the cause. Gastric varices bleed less frequently but more severely than esophageal varices. Dannert W. Radiology Review Manual, 7th ed. Varices. 94. A 67-year-old woman with bilateral lower limb swelling and increasing abdominal girth was scheduled to have an ultrasound as first-line investigation. Ultrasound revealed a complex primarily cystic mass in the adnexa with some solid components. A pelvic MRI was organized for further characterization. All of the following are MR imaging features of ovarian mucinous cyst adenomas that help differentiate them from ovarian serous cyst adenomas, except A. Large size. B. Solid components suggesting malignancy. C. Ed. Philadelphia, Pa, Lippincott, Williams and Wilkins, 2011:852. 94. B. Solid components suggesting malignancy. Serous tumors are more common in both the benign and malignant categories. They are usually unilocular, whereas malignancies may demonstrate solid components and multilocularity. The signal is usually low to intermediate on T1 and high on T2 weighted images. At CT, diffuse somomatous calcifications may cause these tumors or their implants to have very high attenuation. Mucinous ovarian tumors are less common. Mucinous ovarian tumors are generally cystic, but unlike serous tumors may be very large and tend to be multiloculated. They often have variable signal intensity in the loculi owing to proteinaceous or mucinous contents and hemorrhage. The signal intensity of mucin on T1 weighted images varies depending on the Chapter 10. Test paper 5, answers. 295. Degree of mucin concentration. Watery mucin has a lower T1 signal than thicker mucin. On T2 weighted images, corresponding signal intensities are flipped, so watery mucin has a higher signal and thicker mucin appears hypointense. Zhang YY, ETAL imaging evaluation of ovarian masses. Radiographics. 2020, 514-4570. C. More commonly multilocular than unilocular. D. Higher signal intensity on T1W MRI. E. Lower signal intensity on T2W MRI. 95. E. OS navicular A pain behind the heel. The OS acromiale has been MRI. 95. Which of the following anatomical variants and its associated clinical symptom is incorrect? A. OS acromiale impingement. B. Conjoint spinal nerve roots muscle weakness. C. Positive ulnar variants TFC T or D. Discoid meniscus locking. E. OS navicular A pain behind the heel. The heel. The OS acromiale has been implicated as a risk factor for the development of impingement syndrome. Hypertrophic osteophytes may arise at the synchondrosis of an OS acromiale, and the OS acromiale is thought to increase the incidence of osteoarthritis at the AC joint. Medial side foot pain, OS navicular A syndrome, is the most common presenting feature of accessory navicular bone. The pain is aggravated by walking, running, and weight-bearing activities. Positive ulnar variance is associated with ulnar impaction syndrome, or ulnocarpal abutment with TFC degeneration and ulnar-sided wrist pain. Discoid meniscus is an uncommon anatomical variant, more commonly affecting the lateral meniscus. Although frequently asymptomatic, it is prone to cystic degeneration with subsequent tears. Clinical presentation may be with pain, locking or clicking. All kinds of neurological deficits and clinical symptoms may occur with conjoined nerve roots. Besides the different phenotypes of low back or sciatic pain, the most common complaints are numbness and muscular weakness. Bancroft LW, Bridges MD, MRI normal variants and pitfalls. Philadelphia. Heel. 96. A child is referred with a presumed diagnosis of a mucopolysaccharidosis. A skeletal survey demonstrates multiple features in keeping with dysostosis multiplex. Which one of the following radiographic features is not part of the syndrome? A. J-shaped cella. B. Tilting of the radius and ulna away from each other. C. Arrowhead terminal phalanx. D. Calvarial thickening. E. Proximal pointed metacarpals. 97. A patient with cancer has developed bone marrow. Philadelphia. Suppression as a result of chemotherapy and complains of fever and dyspnea. A chest HR. Philadelphia. Pa, Lippincott Williams and Wilkins 2008. Botcher J. ETAL conjoined lumbosacral nerve roots. Current aspects of diagnosis. Urspine J. 2004, 13, 214751. Searsel L. ETAL imaging findings in ulnar-sided wrist impaction syndromes. Radiographics. 2002, 22, 110521. Davlin C.D., Fluker C. Bilateral OS acromiale in a Division I basketball player. J. Sports IMED, 2003, 2:1759. Monster B.J., ETAL musculoskeletal imaging. Philadelphia Pa, Mosby Inc. 2007. 96. C. Arrowhead terminal phalanx mucopolysaccharidosis, MPS, represent a heterogeneous group of inheritable lysosomal storage diseases in which the accumulation of undegraded glycosaminoglycans, GAGs, leads to progressive damage of affected tissues. The typical symptoms include organomegaly, dysostosis multiplex, mental retardation and developmental delay. Dysostosis multiplex is represented by several bone malformations found in the skull, hands, legs, arms and column. Some of the other common skeletal manifestations include macrocephaly with dolichocephaly, facial anomalies, obtuse angle of mandible with prognatism, paddle or oar-shaped ribs, atlantoaxial instability, malformed vertebral bodies, hip dysplasia, coxavalga, proximal humeral notching, inferior tapering of ilium, rounded iliac wings, bullet-shaped phalanges and hypoplastic and irregular carpal and tarsal bones. The abnormal storage of GAGs leads to liver and spleen enlargement. It also damages cartilage layers and synovial recesses in the joints. Palmucci S. ETAL imaging findings of mucopolysaccharidosis. HRCT scan shows. Chapter 9. Test paper 5, questions. 260. Diffuse ground glass opacities. All of the following are likely causes of the CT abnormality, except A. Pneumocystis carinii pneumonia. B. Pulmonary edema. C. Chemotherapy drug toxicity. D. Desquamative interstitial pneumonia. E. Respiratory syncytial virus infection. Mucopolysaccharidosis, a pictorial review. Insights Imaging. 2013, 4444359. 97. D. Desquamative interstitial pneumonia. Opportunistic infections. Pneumocystis pneumonia. PCP. CMV. Pneumonia. HSV. Pneumonia. Respiratory syncytial virus bronchiolitis. Chapter 10. Test paper 5, answers. 296. Chronic interstitial diseases. HP. Desquamative interstitial pneumonia. DIP. RBILD. NSIP. Acute interstitial pneumonia. IPE. Lymphocytic interstitial pneumonia. LIP. Sarcoidosis. Acute alveolar disease. Pulmonary edema. ARDS. Diffuse alveolar hemorrhage. Others. Drug toxicity. Pulmonary alveolar proteinosis. COP. Bronchoalveolar carcinoma. DIP is associated with smoking but not in immunocompromised host. Miller WT, isolated diffuse ground glass opacity in thoracic CT. 98. A 65-year-old man is admitted with intractable retching and sudden onset epigastric pain. A nasogastric tube could not be passed into the stomach. Regarding gastric volvulus, which one of the following statements is correct? A. Etiology is related to unusually short gastrohepatic and gastrocolic mesenteries. B. Sliding/paraesophageal hernia does not predispose to gastric volvulus. C. Organoaxial volvulus is more common than mesenteroaxial volvulus and creates a mirror image stomach. D. Mesenteroaxial volvulus rotates around a line from cardia to pylorus. E. Organoaxial volvulus is associated with upside-down stomach appearance. 99. A 31-year-old woman with CT, causes and clinical presentations. AJR AMJ Rentgenol. 2005, 184:61322. 98. C. Organoaxial volvulus is more common than mesenteroaxial volvulus and creates a mirror image stomach. The etiology of gastric volvulus is related to unusually long gastrohepatic and gastrocolic mesenteries. Organoaxial volvulus rotates around a line from the cardia to the pylorus, whereas the axis of rotation in mesenteroaxial volvulus runs from the lesser to the greater curve of stomach. Mesenteroaxial volvulus is associated with upside-down stomach appearance, whereas organoaxial volvulus is associated with a mirror image stomach. Dannert W. Radiology Review Manual, 7th ed. Philadelphia, PA, Lippincott Williams and Wilkins, 2011:8. With a complex cystic adnexal mass on the left identified on pelvic ultrasound, was referred for a pelvic MRI with a view towards further characterization of the mass lesion. Which of the following statements regarding ovarian tumor is incorrect? A. Granulosa cell tumor is associated with endometrial hyperplasia. B. The presence of fat is specific for teratoma. C. Immature teratoma is mainly cystic. D. Dysgerminoma is associated with raised HCG level. 852. 99. C. Immature teratoma is mainly cystic. Ovarian tumors associated with endometrial hyperplasia or carcinoma includes endometrioid carcinoma, granulosa cell tumor, and occasionally thecoma or fibrosarcoma. Although rare, endometrioid carcinoma is the most common malignant neoplasm that arises from endometriosis. The presence of fat opacity or fat signal intensity in an ovarian lesion is highly specific for a teratoma. Mature cystic teratomas are predominantly cystic with dense calcifications, whereas immature teratomas are predominantly solid with small foci of lipid material and scattered calcifications. Ovarian tumors that are frequently associated with calcifications include serous epithelial tumor, fibrosarcoma, mature or immature teratoma, and Brenner tumor. Malignant germ cell tumors include dysgerminoma, raised HCG level, and endodermal sinus tumors, alpha-fetoprotein level, and are found in younger patients. Jung SE, ET-ALCT, and MR imaging of ovarian tumors with emphasis on differential diagnosis. Radiographics. 2002, 22, 613-0525. 100. B. Homocystinuria. Homocystinuria is an AR disorder secondary to deficiency of cystathionine synthase. Arachnodactyly, metacarp. Level. E. Brenner tumor is associated with calcification. 100. A 48-year-old woman with mid and lower back pain and shortness of breath presented to the A&E department. Plain radiographs showed diffusely osteopenic bones and an old superior and plate depression fracture of L1. CTPA showed acute pulmonary emboli. Plain X-ray of her hand done a year ago at a different hospital showed a metacarpal index of 9.8. What is your diagnosis? A. Marfan syndrome. B. Homocystinuria. C. Systemic lupus erythematosus. D. Acromegaly. E. Soto's syndrome. 101. A 22. Metacarpal index greater than 8.4 or greater than 9.4, depending reference standard used, is seen in 1 in 3 patients, cf 100% in Marfan syndrome. Lens dislocation is downwards and inwards. Chapter 10. CF upwards and outwards in Marfan syndrome. Homocystinuria is also associated with osteoporosis, bowing/fractures, pectus deformities, and biconcave vertebra. There is increased propensity of thromboembolic phenomena due to increased stickiness of platelets. Death is often from occlusive vascular disease. Soto's syndrome is an autosomal dominant syndrome considered a form of cerebral gigantism. Dannert W. Radiology Review Manual, 7th ed. Philadelphia, PA, Lippincott Williams and Wilkins, 2011:1. 22-year-old man with a rapidly enlarging painful right maxilla showed an opacified right maxillary antrum on plain radiograph with destruction of the lateral wall. Axial CT showed extensive new bone formation on both sides of the anterolateral wall of the maxillary antrum with sun ray spiculations anteriorly. What is the diagnosis? A. Ewing sarcoma. B. Synovial sarcoma. C. Antrocarcinoma. D. Myeloma. E. Osteogenic sarcoma. 1078. 101. E. Osteogenic sarcoma. Fewer than 10% of osteosarcomas arise in the craniofacial bones, with most such tumors developing in the mandible and maxilla. The most common sites of involvement are the body of the mandible and the alveolar ridge or the antral area of the maxilla. It may be secondary to radiation, fibrous dysplasia, Paget disease, trauma, osteomyelitis, ossifying fibroma, and giant cell tumor. On CT, the tumor displays a spectrum of bone changes from well-demarcated borders, notably the low-grade osteosarcoma, uncommon, to lytic bone destruction with indefinite margin and variable cortical bone erosion, to the osteoblastic form, where the bone is sclerotic. The majority of osteosarcomas have matrix mineralization, calcifications of the osteoid, or osteoid-like substance within the tumor, and some tumors show a sunburst effect caused by radiating mineralis tumor spiculae. Ewing sarcoma can also occur in this area, although the expected age would be younger. On CT, it often shows the characteristic onion skin appearance of periosteal reaction, and less often a sunburst type of periosteal reaction. Razek Aka. Image. (102). A chest radiograph of a 3-year-old child demonstrates marked right lower zone consolidation with a large nematocele. A diagnosis of necrotizing pneumonia is made. What is the most likely causative organism? A. Staphylococcus aureus. B. Streptococcus pyogenes. Chapter 9. Test paper 5. Questions. 261. C. Bordetella pertussis. D. Mycobacterium tuberculosis. E. Aspergillus. 103. A. Imaging appearance of bone tumors of the maxillofacial region. World J. Radiol. 2011, 3-5-125-34, doi, 10.4329/WJR.V3.I5.125. 102. A. Staphylococcus aureus nematocells are thin-walled, air-filled intraparenchymal cysts that develop secondary to localized bronchiola and alveolar necrosis, which allow one-way passage of air into the interstitial space. They commonly occur in immunocompetent patients and are most commonly associated with S. aureus, followed by Staphylococcus pneumoniae infections. Although there is no clear correlation between the development of nematocells and mechanical ventilation, patients receiving mechanical ventilation have an increased risk for developing complications related to nematocells, including an increase in their size. Other than in hyperimmunoglobulin E syndrome, there is no known genetic or familial tendency for nematocells. The majority of nematocells, more than 85%, resolve spontaneously, partially or completely over weeks to months without clinical or radiographic sequelae. Alsale S. ETAL necrotizing pneumonia complicated by early and late nematoceles. Ken Risper J. 2000. A 3-month-old full-term infant with normal antenatal history presents with multiple seizures. On clinical examination, there is no facial asymmetry, dysmorphology, or ophthalmoplegia. There is marked hypotonia of the limbs. An MRI of the brain revealed a reduction in the number of cortical sulci and shallow sylvian fissures. What is the most likely diagnosis? A. Holoprosencephaly. B. Lissencephaly. C. Band heterotopia. D. Hemimegalencephaly. E. 2008, 15, 3-129-132. Dannert W. Radiology Review Manual, 7th ed. Ed. Philadelphia, Pa. Lippincott, Williams and Wilkins, 2011. 103. B. Lissencephaly, smooth brain, is a severe malformation of the cerebral cortex that results from impaired neuronal migration during the 3rd and 4th months of gestation. The affected brain shows either an absence or a paucity of gyri, agyria, or pachygyria, respectively. The most common clinical manifestations include severe psychomotor retardation, developmental delay, seizures, and failure to thrive. The prognosis depends on the degree of failure of cortical development. In severe cases, death occurs in infancy or early childhood. Prenatal diagnosis of an affected fetus allows appropriate counseling and optimization of obstetric management. Abnormal cortical development is the main manifestation of lissencephaly, although other associated cranial and extracranial abnormalities may be present. Guy S. ETAL prenatal US and MR image. E. Schizencephaly. 104. A 35-year-old woman who is a heavy smoker now complains of slowly progressive dyspnea. A chest HRCT scan shows patches of ground glass opacity interspersed with low-density centrilobular nodules. She does not have any pets at home. The most likely cause of the CT abnormality is A. Cytomegalovirus pneumonia. B. Respiratory bronchiolitis. Interstitial lung disease. C. Hypersensitivity pneumonitis. D. Pulmonary alveolar proteinosis. E. Nonspecific interstitial pneumonia. (104) B. Respiratory bronchiolitis. Interstitial lung disease (RBILD) is a smoking-related interstitial lung disease. The distribution at HRCT is mostly diffuse. The key HRCT features of RBILD are centrilobular nodules in combination with ground glass opacities and bronchial wall thickening. Coexisting moderate centrilobular emphysema is common, given that most patients have a smoking history. Mueller-Mang C. ETAL. What every radiologist should know about idiopathic interstitial pneumonias. Radiographics. 2007, 27, 3595 615. Pneumonia. 105. A 38-year-old patient presents with right-sided abdominal pain. She underwent renal transplantation 2 years previously for autosomal dominant polycystic kidney disease. A CT scan of the abdomen revealed edema to terminal ileum, cecum, and ascending colon. Which of the following is the most likely diagnosis in this patient? A. Appendicitis. B. Tuberculosis. C. Crohn's disease. D. Typhlitis. E. Ischemic bowel. 105. D. Typhlitis, also known as neutropenic colitis. Colitis is a recognized acute colitis affecting the cecum plus or minus the terminal ileum and ascending colon with a predisposition for children with leukemia, lymphoma, and patients on immunosuppressive treatment, i.e., neutropenia. The CT findings include circumferential wall thickening of the cecum, which may extend to the terminal ileum and ascending colon, pericecal fluid, and localized fat stranding. Intestinal TB may be primary or secondary to hematogenous spread from pulmonary TB, and predominantly affects the colon and ileum. Appendicitis may also produce cecal wall thickening, but it is usually asymmetric in nature and rarely extends into the terminal ileum. Backwash ileitis is a chronic complication of ulcerative colitis in which the terminal ileum is affected with a patulous ileocecal valve, absent peristalsis, and granularity of the mucosa. Pseudomembranous colitis usually has a predisposition for the distal colon, but may affect the colon in its entirety. Dannert W. Radiology Review Manual, 7th ed. Philadelphia, Pa. Lippincott, Williams and Wilkins, 2011:88990. (106) All of the following are recognized indications for fetal MRI, except A. Congenital anomalies of the brain and spine. B. Masses in the face or neck. C. Thoracic masses including CCAM, CDHD, assessment of polyhydramnios. E. Fetal surgical assessment of meningomyelocele. 100 106. D. Assessment of polyhydramnios. The most common indications for fetal MRI are neurological. MRI is commonly used to investigate underlying etiologies of ventriculomegaly and morphologic brain abnormalities that are not as readily depicted with US, such as dysgenesis of corpus callosum, malformations of cortical development, and posterior fossa anomalies. Fetal MRI may detect subtle neural tube defects not shown by US and determine the level of the defect in myelomeningocele for potential fetal surgery. The next common indication for fetal MRI is evaluation of suspicious thoracic masses. MRI has the advantage over US in differentiating the liver and bowel loops from lung tissue or masses. This aids in differentiating a congenital diaphragmatic hernia from a pulmonary mass. MRI could be helpful in providing tissue characterization of fetal abdominal masses when US study is nonspecific. MRI is particularly useful in the assessment of pregnancies complicated by oligohydramnios, which can limit the diagnostic sensitivity of US. Salim S.N. Fetal MRI, An Approach to Practice, a Review. JADVRES 2014. 107. Which one of the following is not a feature of benign osteochondroma? A. Presence of variably mineralis/ossified cartilage cap. B. Versiformation. C. Cartilage cap thickness of less than 8 mm. D. Cartilage cap thickness of more than 2.5 cm. E. Invagination of cartilaginous cap into the medullary component of the lesion. 2014, 5550723. 107. D. Cartilage cap thickness of more than 2.5 cm. Pain and increase in the size of osteochondroma raises suspicion of peripheral chondrosarcoma 2 transformation. MRI, in particular T2, weighted images, evaluate thickness of cartilage cap. A cap thickness of more than 2.5 cm is suspicious and warrants tissue diagnosis. Osteochondromas can be solitary or multiple. Multiple osteochondromas are known as diaphyseal achlysis. Multiplicity is not necessarily a feature/predictor of malignancy. Osteochondromas can sometimes turn malignant and become peripheral chondrosarcomas. Sudden pain and increase in size of an osteochondroma raises suspicion of peripheral chondrosarcoma. Neurovascular compromise can be secondary to compression by osteochondroma and does not indicate malignancy. Fracture and bursae formation are related to symptomatic osteochondromas and may be present in benign osteochondromas. Lesion. 108. A moderately large, elongated lesion is seen posteriorly in the thoracic spinal canal on the MRI of a 36-year-old apyrexial, systemically healthy man with lower limb weakness. The signal from the fluid is noted to be identical to CSF elsewhere. No history of trauma was present. What is the diagnosis? A. Extradural arachnoid cyst. B. Extradural abscess. Chapter 9. Test paper 5. Questions. 262. C. Epidural hematoma. D. Syrinx. E. Cystic meningioma. Bernard et al. Improved differentiation of benign osteochondromas from secondary chondrosarcomas with standardized measurement of cartilage cap at CT and MR imaging. Radiology. 2000. 108. A. Extradural arachnoid cyst. Spinal extradural arachnoid cyst, SEAC, is a rare disease, an uncommon cause of compressive myelopathy. SEACs can be found in any location, although they are mostly reported to be located at the mid-thoracic to the thoracolumbar junction, commonly in a posterior position. The underlying cause is thought to be a dural defect. The cause of dural defect can be congenital or acquired. Trauma, arachnoiditis, or iatrogenic cause can result in a small dural tear and subsequent CSF accumulation to develop SEACs. MRI shows an elongated cystic mass, low on T1 weighted and high on T2 weighted images. CT myelography shows communication between the subarachnoid space and the cyst. Confirming a dural tear. Choi SW, et al. Spinal extradural arachnoid cyst. (109) A 45-year-old smoker was sent for an HRCT for disease characterization. HRCT showed patchy ground glass density bilaterally. Some regions of the peripheral lung were normal, while other areas showed a fine reticular pattern representing thickened interlobular and intralobular septa associated with the abnormal ground glass opacity. No honeycombing was seen. All of the following can produce this appearance except A. Lipoid pneumonia. B. Build. C. Goodpasture syndrome. D. Alveolar proteinosis. E. ARDS. 110. Cyst. J. Korean Neurosurg SOC 2013, 54 43558. doi 10.3340/JKNS.2013.54.4.355. 109. B. RBILD. The crazy paving pattern at thin section CT of the lungs is characterized by scattered or diffuse ground glass attenuation with superimposed interlobular septal thickening and intralobular lines. Although originally described in cases of alveolar proteinosis, this pattern has subsequently been reported in a variety of conditions including pneumocystis carinii pneumonia, bronchial-alveolar carcinoma, sarcoidosis, NSIP, COP, lipoid pneumonia, ARDS and pulmonary hemorrhage syndromes including idiopathic pulmonary hemosiderosis, Wegener granulomatosis, Churg-Strauss syndrome, Goodpasture syndrome, collagen vascular diseases, drug-induced coagulopathy, and hemorrhage associated with malignancy. Rossi S. et al. 110. A staging CT is performed on a patient with biopsy-proven gastric cancer. The tumor involves serosa, and enlarged nodes are present 3.5 centimeters from the primary tumor. No distant lesion is identified. Which one of the following is the correct TNM stage? A. T1N0M0B, T1N1M1C, T2 AL crazy paving pattern of thin section CT of the lungs, radiologic pathologic overview. Radiographics. 2003, 23, 615, 09, 19. 110, D, T2N2M0 staging. T1 equals limited to mucosa, or submucosa. T2 equals tumor involves muscle / serosa. T3 equals tumor penetrates through serosa. T4A equals tumor involves adjacent contagious tissues. T4B equals invasion of adjacent structures, diaphragm, abdominal wall, and so on. N1 equals involvement of perigastric nodes within 3 centimeters of primary along greater or lesser curvature. N2 equals involvement of regional nodes greater than 3 cm from primary along branches of celiac axis. N3 equals paraortic, hepatoduodenal, retropancreatic, mesenteric nodes. M1 equals distant metastases. Dannert W. Radiology Review Manual, 7th N. Philadelphia, PA, Lippincott, Williams and Wilkins, 2011:492. 111, D. Congenital adrenal hyperplasia. Classic congenital adrenal hyperplasia, CAH, is due to deficiency of enzymes in the steroidogenesis pathway and can present as a severe salt wasting. T2N1M0D, T2N2M0E, T3N2M0. 111, an 11-year-old girl with tiredness and delayed menarche was sent by her GP to the pediatric clinic for further evaluation. Elevated urinary adrenocorticosteroid metabolites were noted. U.S. abdomen showed large echogenic adrenal masses bilaterally. MRI showed bilateral adrenal myelolipoma. What is the diagnosis? A. Hyperparathyroidism. B. Graves' disease. C. Cystic fibrosis. D. Congenital adrenal hyperplasia. E. Congenital hypothyroidism. 112. Salt wasting form that usually appears with acute adrenal insufficiency in early infancy, men in 7-10 days of birth, and a simple virilising form in which patients demonstrate masculinization of external genitalia, women, or signs of virilization in early life in men. Non-classic, late onset, CAH presents in pubertal girls with symptoms of mild androgen excess. Most lesions are asymptomatic and may be discovered incidentally. Larger lesions, typically over 4 centimeters in size, can present with retroperitoneal hemorrhage or related symptoms. They are associated with Cushing syndrome, congenital adrenal hyperplasia, 21, hydroxylase deficiency, and Conn syndrome, primary hyperaldosteronism. Chapter 10. Test Paper 5, Answers. 300. Lee J.K. Computed body tomography with MRI correlation. Philadelphia, PA, Lippincott, Williams and Wilkins, 2006. Tasker R.C., McClure R.J., Asserini C.L., eds, Oxford Handbook of Pediatrics. Oxford, Oxford University Press, 2008. 112. A 27-year-old woman was referred for a pelvic ultrasound by her family doctor to investigate irregular periods. Pelvic ultrasound revealed enlarged ovaries bilaterally with multiple peripheral cysts of similar size arranged like a garland around centrally increased ovarian stroma. All of the following are associated clinical features commonly observed in this clinical scenario, except A. Hypertension, B. Obesity, C. Insulin resistance, D. Menorrhagia, E. Hirsutism. 130. D. Menorrhagia polycystic ovarian syndrome, PCOS, is the most common endocrine abnormality in women of reproductive age and carries with it significant health risks, including infertility, endometrial hyperplasia, diabetes, insulin resistance, obesity and cardiovascular disease, hypertension, hyperlipidemia, coronary artery and cerebrovascular events. Patients with PCOS have hyperandrogenism, hirsutism and ovarian dysfunction, oligo, or anovulation, and present with oligoamenorrhea. Lee T.T. Roshmi. Polycystic ovarian syndrome. Syndrome, role of imaging in diagnosis. (113) An elderly woman with progressive worsening of back pain is initially investigated with plain films of the spine. Plain radiographs show grade 3 collapse of L3 with grade 2 collapse of at least 2 other mid-thoracic vertebrae. MRI suggested osteoporotic collapse as the most likely cause. Which one of the following is the expected progression of osteoporotic vertebral compression fractures as seen on MR imaging? A. A partial return to normal fatty marrow. B. No change. Chapter 9. Test paper 5, questions. 263. C. The progression is unpredictable. D. An increase in edema and fibrovascular tissue. E. A decrease in normal fatty marrow. 104. Diagnosis. Radiographics. 2012, 32, 616, 43, 57. 113. A. A partial return to normal fatty marrow. The signal intensity of the fractured vertebral body would appear low on T1, weighted images in the acute phase, and would gradually be restored to normal intensity from the periphery to the center of the body as healing progresses. On T2, weighted images, the signal intensity of the fractured vertebral body would appear high, with or without some strongly lowered area in it, in the acute phase, and would be gradually restored to normal intensity with time. Acute fracture and metastatic compression fracture can both show enhancement post-contrast injection. However, contrast enhancement decreases with time in benign vertebral fractures as normal marrow signal is restored. Cho T. ETAL MRI findings on healing process of vertebral fracture in osteoporosis. J. Orthopsy. 114. A 53. (53-year-old man with acute left leg pain in the distribution of the left L5 nerve was referred for an MRI of the lumbar spine. MRI revealed a well-defined lesion with low signal on 11633. Signal on T1W images and high signal on T2W images in the lateral aspect of the spinal canal, in close relation to the L4/5 facet joint. What is the diagnosis? A. Ganglion, B. Synovial cyst, C. Neurofibroma, D. Arachnoid. (114) B. Synovial cyst. Interspinal synovial cysts are extradural lesions that arise from the synovial lining of the facet joints. Most cysts are found at the L4/L5 facet joint, as this is the level where the most biomechanical spinal motion occurs. The differential diagnosis for synovial cysts includes arachnoid cysts, perineural, tarlaf cysts, schwannomas, and migrated herniated disc fragments. The MR imaging characteristics and the neuroanatomic location of the cyst help distinguish synovial cysts from these other lesions. Extradural arachnoid cysts are cerebrospinal fluid-filled outpouchings of the arachnoid membranes that extend through a defect in the dura mater. 2/3 of these lesions occur in the thoracic spine. This helps to differentiate these masses from synovial cysts, which occur most frequently in the lumbar spine. Perineural cysts can be distinguished from synovial cysts because perineural cysts are separate from the facet and are intimately associated with the nerve root. Likewise, schwannomas can be distinguished from synovial cysts on MR images by their intimate association with the nerve root. Furthermore, the propensity for schwannomas to enhance homogeneously after administration of a gadolinium-containing contrast agent helps one distinguish this entity from synovial cysts, which typically demonstrate only rim enhancement. Migrated disc fragments are sometimes found dorsal to the thecal sac, which complicates their differentiation from synovial cysts. They can, however, be distinguished reliably by their relationship to the ligamentum flavum, their signal intensity characteristics, and their lack of degenerative changes in the facet joint. Migrated disc fragments are typically located anterior to the ligamentum flavum, whereas synovial cysts are located dorsal to or inseparable from the ligamentum flavum. Furthermore, migrated disc fragments are usually lobulated and have lower signal intensity on T2, weighted MR images than do the spherically shaped synovial cysts. Merkelda, ETAL. Arachnoid cyst E, Tarlov cyst. Cyst. 115, a 45-year-old man presents to the A&E department with acute onset of dyspnea. Serum biochemistry reveal an elevated creatinine consistent with established renal failure, and a chest HRCT scan shows isolated, diffuse ground glass opacity. The most likely cause of the CT abnormality is A. Pulmonary alveolar proteinosis B. Pneumocystis carinii pneumonia C. Acute interstitial pneumonia D. Respiratory bronchiolitis interstitial lung disease E. Diffuse alveolar hemorrhage. 115. E. Diffuse alveolar hemorrhage antiglomerular basement membrane antibody disease, Goodpasture syndrome, is defined by a triad of diffuse pulmonary hemorrhage, glomerulonephritis, and circulating antiglomerular basement membrane antibodies. Findings of chest radiography may occasionally be normal despite the presence of diffuse pulmonary hemorrhage. Diffuse pulmonary hemorrhage can also occur in patients with systemic lupus erythematosus, typically in the context of established disease associated with extrapulmonary manifestations such as glomerulonephritis. Mayberry JP, ETAL thoracic manifestations of systemic autoimmune diseases, radiographic and high-resolution CT findings. Radiographics. 2020, 6/16/23/35. (116), a 58-year-old inpatient, admitted 10 days before for an acute exacerbation of chronic obstructive pulmonary disease, develops profuse watery diarrhea and severe cramp-like abdominal pain. Abdominal X-ray is unremarkable, but CT demonstrates circumferential wall thickening of the rectum extending to the mid-transverse colon, an accordion sign in the sigmoid colon, pericolonic fat stranding, and ascites. What is the most likely diagnosis? A. Radiation enteritis B. Ischemic colitis C. Diverticulitis D. Amoebiasis E. Clostridium difficile colitis. 116. E. Clostridium difficile colitis. Given the clinical history of recent antibiotic therapy and the introduction to a nosocomial environment, one must always consider Clostridium difficile colitis in the presence of multiple episodes of watery diarrhea. CT, the most sensitive examination for C. difficile colitis, may demonstrate circumferential colon wall thickening with a predisposition for the rectum, but may affect the entire colon, a target sign due to submucosal edema and mucosal hyperemia, pericolonic fat stranding, and ascites. The accordion sign is typical in severe cases of C. difficile colitis and appears as intraluminal contrast media trapped between multiple thickened edema two folds of bowel while the appearance mimics an accordion. There is no history to suggest radiation enteritis, and the involvement of the rectum and distal colon excludes amoebiasis as a likely cause. Ischemic colitis may have a similar appearance, but is usually segmental in nature. Dependent on the arterial distribution. Dannert W. Radiology Review Manual, 7th ed. Philadelphia, Pa, Lippincott Williams and Wilkins, 2011:882. 117. D. Serous cystadenoma ovarian tumors with highly enhancing solid portions, although uncommon, include sclerosing stromal tumor, Sertoli-Leydig cell tumor, struma ovarii, and cystadenofibroma. Jung SE, ETALCT, and MR imaging of ovarian tumors with emphasis on differential diagnosis. Radiographics. 2002, 22, 6/13/05/25. 118. C. Metacarpophalangeal joint, MCPJ, primary OA describes degenerative joint disease with no local etiological factor. It is age-related and caused by high mechanical forces of a repetitive nature on a normal joint. Secondary OA describes degenerative changes within a joint with an underlying etiological factor. Colitis. 117. A 29-year-old woman with a pelvic mass on US is sent for MRI. Axial set MRI shows a well-defined, ovoid solid mass with low signal on T1W images and intermediate signal with multiple round internal cysts on T2W images. Gadolinium-enhanced CT1-FS image shows the mass as having a moderately enhancing solid portion. All the following ovarian tumors typically show solid enhancing elements, except A. Sclerosing stromal tumor, B. Sertoli Leydig cell tumor, C. Struma ovarii, D. Serous cystadenoma, E. Cystadenofibroma. (118) Which of the following is a joint that is not characteristically involved in primary osteoarthritis? OA. A. Distal interphalangeal joint, DIPJ, B. First metatarsophalangeal joint, MTPJ, C. Metacarpophalangeal joint, MCPJ, D. Knee, E. Lumbar spine. Chapter 9. Test paper 5, questions. 264. 119. Cervical spine MRI of a 30. Factor. These may include trauma, CPPD, inflammatory arthritis, hemochromatosis, developmental dysplasia of the hip, DDH. Year-old woman with neck pain, tingling and numbness in the left C5-C7 distribution showed a well-defined intradural mass with signal characteristic similar to spinal cord in both T1W and T2W sequences. The cord was displaced posteriorly without any intrinsic signal change. Intense enhancement was noted on the post-contrast images with a dural tail. What is the diagnosis? A. Neurofibroma, B. Schwannoma, C. Epidural abscess, D. Intraspinal aneurysm, E. Meningioma. 120. A 3-day old neonate presence with bilious vomiting and clinical suspicion for malrotation. Which of the following imaging features would best fit with this diagnosis? A. A duodenojejunal, DJ, flexure located left of the midline. DDH. DDH, AVN, or loose bodies. The joints most commonly involved in primary OA are distal interphalangeal, proximal interphalangeal, first carpometacarpal joint, hips, knees, spine, and first metatarsophalangeal. The joints commonly spared include metacarpophalangeal, wrist, elbow, shoulder, and ankles. Weiss letter R, ETAL Primer of Diagnostic Imaging, 4th ed. Philadelphia, PA, Mosby Elsevier, 2007:452. 119. Meningioma. Meningiomas are well circumscribed and show avid enhancement on contrast-enhanced imaging. On CT, they are ISO/hypertenuating. The hypertenuation reflects the cellular nature of these lesions, but the presence of calcification also contributes. Hyperostosis may be seen, but is not as common as in the intracranial forms. This is due in part to the more prominent epidural fat within the spine. They are most commonly isointense on both T1 weighted and T2 weighted imaging. Some may be hyperintense on T2 weighted imaging, and flow voids may be seen. If they are densely calcified, they will show low signal on both T1 weighted and T2 weighted imaging. Meningiomas prominently enhance on contrast-enhanced imaging, and a dural tail may be observed. Chapter 10. Test paper 5, answers. 302. MRI paragangliomas are well circumscribed and hyperintense on T2 weighted imaging and avidly enhanced on contrast enhanced imaging. The classic salt and pepper appearance associated with head and neck paragangliomas may be seen. The entire spine should be imaged because of the possibility of intradural metastasis. Because of the highly vascular nature, prominent flow voids in and around the tumor commonly occur. A low-signal hemosiderin rim may be seen on T2 weighted images. Neurofibromas and schwannomas can be difficult to differentiate by imaging. Both tumors may widen the neuroforamina, erode bone, and cause vertebral body scalloping on CT. On MRI, both neoplasms are isointense on T1 weighted imaging and hyperintense on T2 weighted imaging. However, schwannomas may have mixed signal intensity on T2 weighted imaging because of the mixture of cells. A central area of lower T2 signal may be seen in neurofibromas and is referred to as the target sign. Carl A. Midline, above the gastric pylorus B. A double bubble sign on supine abdominal radiograph C, retroperitoneal location of the third part of the duodenum D, superior mesenteric artery located to the right of the superior mesenteric vein E, distended bowel loops throughout the whole abdomen on plain radiography. Chapter 9. Test paper 5, questions. 265. Carl A. Soderlund, ETAL Radiologic Pathologic Correlation of Pediatric and Adolescent Spinal Neoplasms, Part 2, Intradural Extramedullary. Carl A. Soderlund, ETAL Radiologic Path. Carl A. Soderlund, ETAL Radiologic Pathologic Correlation of Pediatric and Adolescent Spinal Neoplasms, Part 2, Intradural Extramedullary Spinal Neoplasms. AJR AMJ Rentgenol. 2012, 198, 144-51. 120, D. Superior mesenteric artery located to the right of the superior mesenteric vein. The upper GI series remains the imaging reference standard for the diagnosis of malrotation with or without volvulus. The normal position of the DJ junction is to the left of the left-sided pedicles of the vertebral body at the level of the duodenal bulb on frontal views, and posterior, retroperitoneal, on lateral views. In children with acute duodenal obstruction, the upper GI series may depict a Z-shaped configuration of the duodenum in the presence of obstructing peritoneal bands, or a corkscrew-shaped duodenum in the presence of volvulus. In children who have bowel malrotation without volvulus, the upper GI series shows an abnormal position of the DJ junction. The detection of the double bubble sign suggests duodenal obstruction. In infants in whom the radiograph demonstrates a double bubble, one should consider both intrinsic and extrinsic causes of obstruction. The intrinsic causes are duodenal atresia, duodenal stenosis, and duodenal webs. The extrinsic causes include annular pancreas, malrotation of the gut with obstruction produced by midgut volvulus or by lad bands, and preduodenal position of the portal vein. The proximal left-sided bubble is the air and fluid-filled stomach. The duodenum represents the second bubble to the right of the midline. The third part of the duodenum is a retroperitoneal structure. Normally SMV is to the right of the SMA. Distended bowel loops throughout the abdomen would exclude any significant midgut obstruction. Applegate K. ETAL intestinal malrotation in children, a problem-solving approach to the upper gastrointestinal series. Radiographics. 2006, 26, 5. 1485-500. Traubesai J. The double bubble sign. Radiology. 2001, 220, 2 for 63.